Basically, I am a simple-minded orthopedic surgeon, and that also I don't do the entire gamut of orthopedic surgery. I practice just hip and knee. So yes, my whole life deals with arthritis, and all the time I'm seeing patients trying to prevent arthritis as much as trying to treat the end stage arthritis, which I do with replacements. And preventing arthritis, of course, I deal with sports injuries. I try to do a lot of patient education, because I think it is our primary aim to try and stop these things from happening if we can. What's happening? Why is it not? So yes, I was asked to talk today on basically it is the link between osteoarthritis and cardiovascular disease. And I can speak on osteoarthritis, but as regards knowledge of medicine and cardiovascular disease, I would definitely rely on my colleague to give you excellent information on that. I will tell you a few points about arthritis, and probably as much as a simple brain can talk. I'll try and put it across basic facts about arthritis and some things which hopefully you will be able to go back and maybe inform your patients about. So the interesting thing is, we talk about relations. We talk about one thing, and we relate one disease with another. There's no doubt, with more and more specialization in medicine, we are getting to see only one aspect of things. Now, I myself, I'm a hip and knee surgeon. So yes, I'm seeing only knees and hips. I don't treat anything else all the time. But at the end of the day, we must not forget that there is a patient attached to that knee. And it is that anytime we are treating a knee problem, or any problem for that matter, we are not only treating arthritis in the knee. So we can't treat patients like the IT guys press buttons on the computer. For one disease, there is never one treatment. It is, along with treating that particular condition, we are treating somebody's brain. Depending on whether somebody wants to accept a particular treatment is how we have to dictate, or how we have to make or formulate a plan for every patient. So it is so important, and I think it is really nice of Cadila to bring about this kind of amalgamation of different principles, and a lecture where, and I should say I'm privileged to stand up on this audience and talk about link between a surgical and a medical branch. So it is very important for all of us clinicians to have a little idea about what others are doing, because that definitely will have an influence on on practice. Talking about surgery, there's a lot of negativity about surgery. There is a lot of talking about replacements. People have seen many downsides of it. People have seen complications related to it, and patients don't want to accept surgery initially as the first thing. But at the same time, we don't realize that there are a lot of side effects related to medicines, long-term medicines, particularly analgesics, which a lot of orthopedic surgeons like myself prescribe all the time. Secondly, we in India tend to get a lot of influence with flashy new innovations. Now, innovation is very good, and this is all about an innovation conclave. And unless there is research and innovation, there is no meaning to clinical practice. If I just stop, or rather just go full-time into practice without having any teaching or reading or attending some updating my knowledge, what happens is the world is going to change, and I don't realize what I think of as very good today may be obsolete tomorrow, because it's all about change. Similarly, we tend to get influenced with flashy new treatments. Now, trying to say, for example, prevent knee replacements, there are a lot of advertisements out there saying somebody went in for some magnet therapy, somebody went there for some sort of exotic massage, and they are hopping and skipping next day. So, how much of this is research founded is very important for us to realize before we advise it to our patients. At the end of the day, whatever we want our patients to get better. So we don't want to advise them anything which, they will come back and tell us, doctor, you advised me, and I went for this, it's not successful. So we really, when we think about innovation, it has to be good founded on good based research. Whenever we are advising treatment, we have to look at what is the evidence behind the success for that treatment. So again, relations, very important. So when I talked about relation between one thing and the other, relationship between osteoarthritis and cardiovascular disease, I thought about, everybody associates drinking with, all sorts of, associating it with kind of bad things. So I said, let us talk about, what can happen, just to kind of introduce the topic of influencing one thing on the other. So you can see this guy sipping beer, and there's a lady sitting in front of him. So there are probably some good effects of drinking alcohol. There are with all the abuse it gets. Is this clear? Should we reduce the right on the stage? It's okay. And now that effect is gone, comes back to the original. So he thinks it's not good, he wants to order some more beer. Anyway, that's different. Coming to osteoarthritis and cardiovascular disease, there is no doubt, and there is a fair bit of evidence out there which shows that people with osteoarthritis are definitely at increased risk of cardiovascular disease. And it is not very difficult to understand. We can talk about all those papers and talking about actually substantiating what is there, but it is obvious that somebody with osteoarthritis will have less mobility. Less mobility is related to increased risk of cardiovascular diseases. There is association between hand arthritis and cardiovascular disease, as well as risk between relation between hypertension and knee arthritis as well. And you can say it is definitely arthritis is associated with increased morbidity, which comes with cardiovascular disease as well. To think about, I don't want to vomit out all that evidence here, but what is important is with cardiovascular disease as well as with osteoarthritis, there is some inflammation out there. I don't think my pointer is working, but I'll try and, there it is working. So what actually happens in arthritis is there is inflammation of the synovial tissue, which then leads to slow breakdown of cartilage. In most of the cases where we see in India, it is basically position related, mechanical related, but there is definitely an inflammatory component higher in conditions like inflammatory arthritis, which are out there, which are more and more recognized now with emerging branches of medicine like rheumatology. So, other things which are, inflammation is one thing. Other thing is, the common factor for both these conditions is definitely obesity. And I just put that as a little bit of an entertainment. But what does obesity really do? Definitely, it decreases activity. And we know that activity is going to be definitely associated with increased mortality. It is no doubt to say that it is a vicious circle: weight gain, osteoarthritis, physical activity, and definitely they are related to cardiovascular disease. The other common factors that we see often here are play of hormones. When ladies stop having their normal hormones is when they get increased risk of osteoporosis. Associated with that comes osteoarthritis many times. And of course, the same thing, we know there is a relation. The physicians and the cardiologists out here know much better than me the relation or the protective effects of estrogen on the heart. Secondly, a lot of orthopedicians like me prescribe these drugs, and they have been pretty much the mainstay of treating pain, which is by far the largest complaint that all doctors treat. And we know that has deleterious effects on the kidney and the heart, with all the other harms that come with it. So just to understand the basics of arthritis, yes, we talked about inflammation. There are different types. There's mechanical and there is the inflammatory type of arthritis. We don't want to go into the detail there, but it is important to understand the stages of arthritis, because what has happened nowadays with the increasing commercialization of medicine is we, many people, many of our educated middle-aged people start thinking, oh, I'm now 50 plus, I've started getting knee pain, am I going to end up with a knee replacement? No, that's not the thing. And you have a lot of our, business corporate hospitals out there which are just waiting. You say you want a knee replacement, they'll say not one, we'll give you two. We'll give you two for less price and things like that. So it is, at the same time, if it is not done properly, it gets a lot of abuse, and that's when they are not very successful out there. Talking about knee replacements worldwide, specialist knee surgeons who are doing knee replacements have seen that a good 20% of people having had knee replacements are not entirely satisfied with their surgery. So even though it is the number 3 of the most influential surgeries out there on the planet. The number 1 of all surgeries is hip replacement, number 2 is cataract, and number 3 is knee replacement. So definitely it rates higher than anything else as regards quality of life. But at the same time, knee replacement is not a treatment for knee pain, and that is why I would like to highlight on this slide. It is very important to understand the stages of disease. We treat pain most of the time, but pain may not always be related to end-stage arthritis where bones are rubbing on bones. So if that happens and somebody has really bad deformities and is not able to walk, where you can see the mechanical component, yes, that can definitely be bettered by a knee replacement. That also if the patient is comprehending and willing for it. People with knee pain, with these grades of arthritis, we have very well identified grades in the late 1980s, but many times we don't follow these basic principles many times. We are treating people with this type of X-ray with a knee replacement, and that is when it is not going to be successful. That is where we have to bring about different types of innovations, treat them in different ways, understand the importance of different types of conservative treatments, because we do surgeries, or rather replacements in grades where it is only cracks in the cartilage or less than 50% or about 50% of damage. They will be having other related problems, or they have much of a higher chance of developing other problems related to the surgery as such. So that's why it's important to understand that. Now, in our country, we were talking about stages of treatment. Like, we have different modes of treatment. I'm not just talking about allopathy. There is all other different branches of treatment, and they are quite popular, and people are looking for new exotic stages of, exotic different modes of treatment. So that's why I like to put up this slide. It's not that this correlates with the stages of arthritis. This is just a bit of a filler. So you have the first stage, allopathy, then they go to homeopathy, then there's sympathy, and of course last, that's not very far away. So, oops, I'm not able to go to the next one. So, coming to non-pharmacological treatment, it is very, very important to understand the basics of what has led to the arthritis. And that is why a good specialist consultation with the patient for understanding what their whole environment is about, understanding how that came about, what their mental makeup is like, is very, very important before deciding what treatment to do for that individual patient. One cannot decide just whether to have a knee. Of course, that X-ray is an important factor over there, but just anybody who has that X-ray does not mean they need a knee replacement. I have driven across coastal Karnataka, driving from Mangalore to here today, and I saw many 70-year-olds, Ajjas around, Kundapur, Bhatkal area, happily walking like that all along on the highway. Do they need knee replacements? No. They walk for 2 kilometers without any disability. So it's a correlation of what the patient feels like, whether they have a disability and whether that correlates with the X-ray. And there are people who will get better with all these sorts of things. So if the patient is happy, that doesn't mean the computer says you need to do a knee replacement. That is when it will not be successful. So, non-pharmacological management. It's important to understand diet. Now, my grandfather lived till 90 years of age without any medical problems. He was, riding a cycle till he was 80 plus almost, because he didn't have access to all these sorts of things. Look at the amount of sugars we are consuming. Our kids love to go to canteens, college canteens and all, and consume all this. Look at the amount of sugar that they are consuming on a daily basis. And we talk about how we are getting fat. We are eating processed foods. We are not getting the amount of exercise that we really should get. We are living in a country. I've lived in England myself for about 12 years, and people used to say, oh, you're lucky, you're from India, you have so much of sun. And now, when we are in India, how many of us really go out for a walk in the sun? How many of us get enough vitamin D? Are we getting good quality bones for our children till the time they are 35? That is when you make your peak bone mass density. I used to walk to school, but today, are our roads safe enough? How many of our children are walking to school? Or are we dropping them to school in air-conditioned cars? This is what we are getting today. That is exactly what we have to tell our patients. They have to realize where their diets are going, and it is about sitting and counseling the patient about exercise. There is a lot of less importance given to controlling, or rather managing, early stages of arthritis with the right footwear and understanding how people are exercising. People, when they talk about exercise, they'll go and do some gym membership, and the fact that they're paying 15,000 rupees per month makes them feel better. But that doesn't contribute either better towards the heart or their knees. It is about doing exercise, and not just any exercise, understanding which exercise can be right for which joint and what pattern of disease they have. Of course, weight loss goes without saying, and physiotherapy. Physiotherapy is not, again, just about going there and letting the physiotherapist put some light or massage your knee. It's about doing specific exercises. So what physiotherapists should really be doing is training the patients to go home and do their own exercises, not coming there again and again and doing physiotherapy sessions. That only betters the physiotherapist's muscle and his wallet, to be at the end of the day. So, coming to pharmacological treatment, of course there are those pain medications, and I'm not standing here to criticize painkillers. At the end of the day, they have been the cornerstone for managing a wide variety of conditions. But by and large, they are good things to use. I think it's an LCD screen, isn't it? That's why the pointer is not working. Doesn't matter, I'll manage without. It is, pain medications, they are wonderful drugs if used in an acute situation. Nothing better than, whatever. I'm not saying paracetamol, brufen. We have abused ibuprofen so much, but at the end of the day, in the right person, ibuprofen is a wonderful drug. If we have fever, there's nothing else but paracetamol that we can take, and it works wonderfully. But we must understand where to restrict. It is a problem. People start going from one doctor to the other doctor, and they get different they get the same medication, but from a different brand. And that is where the problem happens. We don't understand what our patients are taking from elsewhere before we prescribe other medications. The good news over here is there is a lot of innovation into what are called chondroprotective agents as a group. And there is a large number of drugs under that. It started about 15-20 years ago with drugs called glucosamines and chondroitins. Now, those are basically constituents of normal cartilage and synovial fluid. There is no clear evidence to say that those kind of drugs work, but having said that, I prescribe a fair amount in my practice, and to the right patient, it does have a fair amount of benefit. And there's emerging evidence now. For glucosamines, the American Academy and certain scientific committees in Europe have given moderate to good evidence that it does make a difference. Of course, people are going overboard and say it increases the joint space and it will change that space from 50% to less than 50%. That is not evidence founded. But what happens definitely is, if that can be combined with the right sort of exercise and things like that, yes, it makes a good difference. And you have to cater it for the right patient. Everybody may not do well with glucosamines. What is not very well talked about them is, everybody thinks chondroprotective agent means you can just prescribe it, no side effects. But the glucosamines out there, particularly if patients are on cardiac drugs, there is some known incidence of glucosamines increasing the risk of bleeding. Secondly, it may not work in everybody because it doesn't have a it doesn't have action on the nociceptive cells. So there are other things out there. There are a large new variety of things coming up, and it can be very, you can say, judiciously prescribed in the right patient in the right stage of disease, and that is, to decide on the individual patient. So glucosamine chondroitin is where there is evidence, but there's emerging evidence with some things like collagen substitutes. There are various things like MSM, dicerin, things like that, which have less evidence, but at least 2-3 of these things are quite safe and can be combined with the right vitamins and with other modes of conservative treatment. So then I looked up, surgical treatment. So if you look on Google, which is the best surgery, scientific evidence tells us that the best surgery on the planet over there is joint replacement. That is total hip replacement. Total hip replacement has really, really high success rates if done properly. And it is close following that is cataract and knee replacement. But knee replacement people's satisfaction rate is lower because of many things associated with the knee which we have not yet very well understood. And one important part, of course, in our country is what we were talking about, not exploring the conservative method enough and not doing the right surgery in the right way in the right patient. But if you Google what is best surgery, this is what comes. I'm just highlighting the importance of conservative treatment with this slide. So don't take it literally. If you can do the surgery yourself, it's very good, isn't it? So somebody's advertising that with green tea. I don't think it's going to work for everybody. I think the other lady is going to try it. It doesn't work for her. So, again, it is what works for one person may not work for the other. Now, there are drugs like this. This is basically haldi. It is turmeric. So people are coming out with innovation on this drug. The evidence so far says it does have some pain-killing effect. Now thinking about it, if it was that effective, Indians should not have got arthritis at all, because I don't think any of us make food at home without turmeric in it. So the evidence over there is the doses that are required for all these effects are relatively high. And it remains to be explored as to how safe and side effects and things like that will be there if we give higher doses. But I suppose there might be a place, so that is why we need companies like Cadila to provide us with the evidence in the long run. The next is, after going, if you are not successful with all these different modes of painkillers and all the other protective medication with the other conservative modes, there is definitely scope for injection treatments, and there is good emerging evidence on that front. Now earlier, even the physicians would know very well the commonest injections that were given from orthopedic side were steroid injections. Now definitely, and that is why I've put up that slide there. So the oldest and most famous out them is the steroid injection. A wonderful treatment if it works, if it is in the right stage of disease. That is particularly in today's day and age, I would give it for a case of flare-up of arthritis where there is a predominant inflammatory component. So it's wonderful. Having said that, that should not be repeated. If somebody is repeatedly having steroid injections, we know very well with evidence that the effect of that injection is going to be less every time. And there is so much evidence that in the long term, steroid will only increase the scarring and actually aid to destroy the cartilage in that knee, which is why we've got the other two which are coming up now. So there is, you can say, relatively new but very well researched now hyaluronic acid injections. So what are these? These are basically trying to replenish the synovial fluid. They do have an effect of reversing some inflammation. Having said that, it won't work where it is predominantly inflammatory. Now many times in inflammatory conditions, I combine this with this as well. It can be combined into one injection and given at the same time. Now there are different types of hyaluronic acids. There are predominantly the ones that were made were short acting and you have to give them repeatedly. Now those are known to be not so good. because the problem with injection treatments is every time you're injecting a joint, there is the potential of pushing in a bug, basically infecting it. So it should not ideally be done in a routine OPD at all, because you could do more harm than good. But if done properly for the right patient, there is some emerging evidence for using things like hyaluronic acid. The good effect of hyaluronic acid is the right compound has to be used, and they tend to be slightly more expensive, but they do work in the right patient. So it can be combined with steroid. The good thing is the effect of this will be slow. Steroid, the patient will feel better the next day, but technically that drug will last in there for just about 3 weeks. So, the patient might have beneficial effects for maybe 2-3 months. With this, it can be prolonged for even up to 6 months to a year if combined with exercises and things like that. The new kid on the block is using your own blood, centrifuging that blood and using the growth factors from platelets to try and reverse some changes in the joint. So the way PRP works is basically it is trying to provide, it's trying to reverse the, again, the inflammation and the degradation element of cartilage. It's trying to reverse that. So there is again level 2 evidence from early studies that it might work if selected in the right patient. And that is something which is probably worth exploring. The good evidence for PRP is not for pure osteoarthritis. It is more for conditions like tennis elbow and plantar fasciitis, things like jumper's knee, tendinosis, tendinitis conditions where it very well works. And that again can be combined with HA and steroid as well. So these are the other things that we can do. Coming to surgery. The good thing about surgery, which I myself learned when I explored and read about this topic, is that surgery is known to actually in the long term reduce the cardiovascular risk for the patient in the long term. So it is clear that with surgery, if somebody is going to be mobile, it is self-explanatory that the risk for cardiovascular disease and long-term mortality will be less. So people think, oh, surgery risky, but actually it is much less risky in the long term for the right patient. Don't get me wrong. If you think in the long term, it is much less of a risk if considering keeping popping pills and having problems related to mobility with increased risk of falls, etc. What are the different types of surgery we can do? Of course, there's a whole range depending on the right patient. There was earlier for arthritis what was called as going inside the knee with keyhole, washing out the bad synovial fluid, cleaning the joint and things like that. Now that is definitely known not to work, and there is definitely evidence against it. So there is still practice about trying to go in there, wash the joint and feel better temporarily. Actually, there are a high number of situations when you have bad exposed bone in the joint. When we do an arthroscopy, it can actually increase the pain because during the arthroscopy we are pushing fluid at high pressure. So keyhole surgery essentially is surgery for somebody to prevent arthritis, is what the way I think about it. So if somebody has a sports injury with cartilage damage, that is when you can do keyhole surgery to take care of that cartilage and try and restore a normal joint. Why are we trying to restore a normal joint? Because we want to stop the mechanical elements which will increase the wear and tear process in the joint. And that is where keyhole surgery works. For arthritis, keyhole surgery does not work. What will work better is those injections. So unless there is a mechanical component, that is definitely out. There are definitely other things. We have to check the patient's alignment. We have to check the pattern of arthritis. And for a young patient with arthritis, partial joint replacement is something which we can definitely do a lot more in India. There is realignment surgery, breaking and realigning the bones, which we can do a lot more in India and prevent people having joint replacement at a very early age. What is happening in India today is the average age for knee replacement around the world is between 65 and 70, something like 68, 69 years. But unfortunately, we are seeing a lot of our young people having arthritis, and this is what having knee replacements. This is what we shouldn't be doing, because the technology for knee replacements it is not like for hip replacements. I'm not scared to do a hip replacement in anybody. I've done people even in 20 years of age because the conditions are like that. And we have implants which will last long. Knee replacement, the implant is designed for somebody who is a retired individual. So typically for somebody after 60, yes, if the condition is very bad, something like rheumatoid arthritis, yes, we can do that at a young age. But we don't want to do knee replacement as far as possible, a total knee replacement in somebody less than 60, as far as possible. So depending on the pattern of arthritis, there are other modes of surgery. So if the arthritis is localized, we can definitely do half joint replacement, and that patient will have a good quality of life for whatever number of years. The advantage of this is having one of these, it's very easy if the arthritis then spreads to transfer it to this surgery, that is total joint replacement. But if somebody has a total joint replacement at about 50 or less, and then that starts failing at 65, 70, when they are still young, our life expectancy is increased to beyond 70 now. So if somebody is having a joint, a total joint and has problems, revising a total joint means then they'll have to have metal right down from the middle of their thigh to the almost up to the ankle, and that is not something good, which is why we should explore those other options of surgery. What I do in Mangalore is we do a patient information kind of get together every month, once a month, and we try and educate patients about understanding their disease and things like that. These are people who have different types of treatment. We make sure that if you want joint replacement, it's not for somebody who wants to sit at home and just walk from the toilet to the dining room. Those people don't need joint replacement. If you have joint replacement, and there are 80-year-olds in that picture as well, they can be walking out there in the park, and they should be. You should not be able to differentiate a patient who's had a joint replacement from anyone, you know, like you and me here, for that matter, and they can be given all sorts of activities. So that's them walking in the park. So you can see somebody like this with joint replacement today. That lady is I think 68 years old when we did it, doctor's mother. You can see how difficult it is for her to walk even without support. And that's literally 3 days after the joint replacement. You can see her, you can see the obvious difference. She's walking with one support. By 1 month's time, she'll be walking without the stick, and by about 3 months' time, you can get them kneeling down. People of different religious faiths who want to kneel down for prayers can very well do that with a joint replacement. There is no reason why they cannot have a normal life. This is somebody who's at 67 years having a joint replacement. About 1.5 months later, he wants to ride a scooter. No problem whatsoever. So people can be rehabilitated into this. And somebody who's had bilateral joint replacements there, they want to sit down like that for their puja and things like that. Entirely possible. There is no problem whatsoever. But it is about doing the right thing with the right technique in the right patient. So that's about innovation. Oops. Fashions change. That was how trousers were worn in the 70s. That's how it became in the 90s. So it's coming further and further down the waist. Comes even lower. And they talk about what will it be in 2030. Probably something like that. Anyway, talking about few new things. So there is a talk about stem cells. Stem cells work for young people. We have to use these things. There's good innovations out there. Sorry, I won't be too long. I hope I'm not boring. So stem cells work if done in the right stage. So they are not for osteoarthritis. They won't work for osteoarthritis. What evidence is there for osteoarthritis is maximum with PRP. Stem cells work for cartilage lesions. People who've had a proper cartilage, a circumscribed defect over there in a cartilage in a young person who has no other arthritic changes, yes, we can make it work by doing keyhole surgery. They work for other conditions in the body, but there's a lot of commercialization with this industry without evidence there. So yes, it has very good evidence for cartilage, localized cartilage lesions, not for osteoarthritis. There is a lot of other things. There are some implants. They talk about it in arthritis, but there is no evidence. First, people have tried plastic implants, putting them in the knee, and have had lots of problems. So we don't want innovations. We don't want to use it on our patients unless there is a good evidence at the end of the day. So these are few things being researched. There are cellular implants. There are some implants which are made with cartilage-like material and with, made with constituents of natural cartilage. There are some, people trying to use adipose stem cells and trying to modify DNA, but, no real evidence there. It's important to do the right technique. So if you're doing some technique, you've got to be well prepared for it. Not just try a new thing and realize that you failed. So that definitely we don't want to happen to our patients. And again, just hearing about some flashy things, at conferences, don't just go and follow it, because it might lead to a really, really bad side effect. That's that about innovation. There are some very good implants. I'd just like to make an end note with that. These are implants which are very cheap implants. There is all talk about Indian implants and foreign implants. I put two examples of implants these are foreign implants which have got very, very good evidence on the joint registries, but unfortunately the usage of these implants in India is probably less than 10 to 15%, and we are going towards foreign really, really expensive implants which are not worth it. These implants are producing good results, so we can definitely get down costs of surgery and use implants like this, use things with evidence, and that is where the innovation is. With the right technique, use innovation in technique rather than just running behind technology. Thank you.